Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
This film will demonstrate a gingival autograft procedure performed on the buccal aspect of the mandibular left first molar. The second molar has been lost, and tissue resorption has occurred in the saddle area. A periodontal pocket extending to the mucogingival junction is present on the buccal aspect of the first molar. A gingival autograft will be obtained from the maxilla because there is insufficient gingival tissue distal to the mandibular molar to permit a pedicle flap from this edentulous site. The study cast shows the area of alveolar mucosa that will be replaced by the maxillary gingival autograft. The foil represents the size of the graft area. This graft procedure is indicated because there is a minimal zone of attached gingival at this site, and the pocket depth extends apical to the mucogingival junction. Anesthesia is infiltrated into the mucobuccal fold of the mandible and maxilla. An adhesive foil template is placed in position at the recipient site and outlined with an indelible pencil. This outline will ensure that sufficient gingival tissue will be taken from the donor site for grafting to the recipient site. The incision will follow the penciled outline. The foil template is transferred to the donor site, which in this particular case is the buccal aspect of the edentulous area, posterior to the first maxillary molar. Since there is a sufficient zone of gingiva present in this area, the buccal rather than the palatal surface is used. However, the palatal surface, also being masticatory mucosa, could have been used for this purpose. If the palatal tissue is utilized, this is called a free soft tissue autograft. It is important to recognize that the narrow margin of gingiva present on the mandibular molar will be preserved. The alveolar mucosa will now be removed from the recipient site. The incision is made along the penciled outline, care being taken not to disturb the narrow gingival band which will be allowed to remain. The alveolar mucosa is carefully dissected from the underlying periosteum. This type of dissection permits the retention of the periosteal bed upon which the gingival graft will be placed, thereby assuring vascularity and survival of the grafted tissue. Any unnecessary tissues left on the periosteal bed can be removed after the surface mucosa has been dissected away. It should again be emphasized that a pedicle flap from the edentulous area distal to the mandibular molar was not used because of insufficient available gingival tissue at this site. The tissue loss was created by resorption of the edentulous ridge following extraction of the second molar. The scalpel is used to sharply dissect the mucosa from the underlying attachments. This is frequently the location for the origin of buccinator muscle fibers. The loose connective tissue and muscle fibers must be removed from the periosteal bed. Soft tissue nippers are used for this purpose. The removal of this tissue will ensure that the graft itself rests on a flat periosteal bed. The periosteum covering the cortical plate of the alveolar process is not disturbed. This flat, well-prepared bed is free of soft tissue irregularities and is now ready to receive the graft from the donor site. The scalpel again follows the penciled outline at the donor site. This will be a split-thickness graft of attached gingiva that must be carefully dissected from its underlying connective tissue bed. The connective tissue itself is split so that the lamina propria remains with the graft. The dissection proceeds from the anterior to the posterior. The inside of the graft is kept as flat as possible, and care is taken to allow the underlying tissues, including the periosteum, to remain at the donor site rather than be taken with the graft. The graft is gently held with Alice forceps and detached from the donor site. Care should be taken at this point not to allow the graft to be sucked into the aspirator tip. If any trimming or other preparation in the graft is required, it can be accomplished at this time. The use of the hemostatic agent, isobutyl cyanoacrylate, is placed over the donor site. This reduces any hemorrhage which might interfere with the procedure. Note that this hemostatic agent polymerizes almost immediately upon application. It serves as an excellent dressing to cover the donor site and control any bleeding while the surgical procedure is completed. Excess cyanoacrylate is removed from the cheek after it hardens. The gingival graft is placed into position on the buccal surface of the mandibular molar. A suture is placed through the anterior border of the graft into the adjacent alveolar mucosa. The narrow marginal collar of gingiva, which has been left in position, will be the superior border to which the graft is secured. The suturing has now been completed. Notice that the graft has been sutured to the gingival margin, the mucosa at the vestibular fornix, and to the mucosa anterior and posterior to the site. After a warm saline-saturated sponge has been briefly held against the graft to minimize submucosal bleeding, a periodontal dressing is applied. This is a Baer-Sumner pack, which has been covered with a modified Kirkland pack. Both the pack and the donor site are covered with surgical adhesive foil. A post-operative view taken 5 weeks later shows that the gingival graft has survived. It replaces the alveolar mucosa that was on the buccal surface of the molar tooth. The probe reaches to the superior border of the graft when it is introduced into the buccal gingival sulcus. Muscle trimming demonstrates that the gingival graft acts as a buffer to prevent the muscles of facial expression from putting tension on the gingival margin. Approximately 6 millimeters of gingiva has been added in this site. The donor site in the maxilla has completely healed.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.